Okay, share same thing, low simply manamity, share so nice.
Screen to your lamb,
Yes, yeah, how
Okay.
sa yeah.
No, hold screen to your account. Thank you, thank you. So, so good morning, everyone. We're in California and US. Good evening in Myanmar and the UK and Australia. I don't know what time at this time. So, welcome everybody. Thanks for inviting me for the symposium. So, it's the symposium actually is not like kind of lecture actually. So, as you know, COVID-19 is I have to say thank you for all the Myanmar physicians and frontline worker for helping Myanmar people over there. Um, Now, so we are still learning how to manage COVID and including, the diabetes in COVID, and we are still learning. So this is a symposium actually, so, we are sharing our experience, so not like giving a lecture. So last week, we had symposium together with University of Mandalay and University of Medicine Mandalay and University of Medicine Magwe. Um, so we share our experience from Mandalay and from California. So at the end of the talk, so please feel free to share your experience. We are learning from each other. So your opinion and your experience will be welcome at the end of the talk. Now, COVID-19 is associated with worse outcome in patients with diabetes, as we all know. So if you have a diabetes type 2 or type 1, if you are obese, you have much worse outcome than your colleagues. And similarly, the mortality rate is much higher if you have diabetes and COVID. Now, COVID-19 patient, we observe that their diabetes, even without history of diabetes, and they could have a new onset diabetes. And similarly, those with pre-existing diabetes, they could present with DKA, HHS, and also worsening of diabetic control in the presence of a history of diabetes. Now, SARS virus that cause COVID-19 bind to ACE2 receptor, which is expressed in other organs, including pancreatic beta cells. And therefore, so there's a question on if that COVID-19 virus damage pancreatic beta cells, causing you onset diabetes. There's a bidirectional relationship between diabetes and COVID-19. Diabetes is an important risk factor for severe COVID-19 and mortality. Similarly, new onset diabetes, worsening of diabetes control in pre-existing diabetes has been observed in patients with diabetes, as we all know. COVID-19 is knowledge in progress. I want to quote Sarah Remera. Actually, I got it from Sarah Union Thing, Facebook. I like that so much, so I'm going to quote without their consent. I tried to get their consent, I couldn't reach them, so I go to show you. So that Sarah Remera is, one of my teacher, who trained me before. So I went for MRCP exam in UK. So Sarah Remera, I don't know my So, the doctor in the time of COVID, the road is long and the cure not near. Experience is limited and decision difficult. So that second sentence is very true, especially for diabetes management and COVID-19. Currently, we don't know so many facts about diabetes management and COVID-19. So COVID-19 related diabetes, new onset, once they have it, will they go away? When they recover, is it type 1 or type 2 or new type of diabetes? We don't know. So how about patients with pre-existing diabetes? What is underlying pathophysiology? As I said before, is it because they are damaging beta cells or because it increases insulin resistance? We don't know. There's so many don't know in management of diabetes. And similarly, and more importantly, we don't really know how best to manage hyperglycemia or new onset diabetes or pre-existing diabetes in COVID-19 patients. And therefore, a group of international diabetes experts now form a COVID registry, and they have a group. So they try to get information from around the world, patient diabetes, hyperglycemia in COVID patient, and try to get information, and they are collecting data to answer these questions. Now, so if we don't know about how to manage or best manage diabetes and COVID, so how we should approach those patients? Well, we know how to manage steroid-induced hyperglycemia in non-COVID patients. And we also know a little bit about, diabetes management in general population. And therefore, my talk will combine all those, and finally, a few slides, we'll come up with some suggestion on management of steroid-induced hyperglycemia in COVID-19 patient on dexamethasone. So I'm going to start with, so my talk is actually 3 parts. We start with steroid-induced hyperglycemia in general, so that we know to some extent how to manage, followed by management of diabetes in general and COVID-19 patient. We'll put those two together, and at the end, a few slides, we're going to go over management of steroid-induced in hyperglycemia and COVID-19 patient. So we're going to start with steroid-induced hyperglycemia in general population. So what's the best way to manage steroid-induced hyperglycemia in COVID patient? Well, we're going to start with to answer the question, where this slide is important. So this is from up to date. So management of diabetes in COVID patient is similar to management of other hospitalized patients with diabetes, where this statement is not based on any evidence or any research study, is based on the expert opinion. So the only exception is they have extreme labile insulin resistant that will require a large amount of insulin, and that insulin resistance resolve with improvement in COVID-19 infections, and also discontinuation of steroid, of course. And there's also the need to minimize frequency of injection to maximize safety of your staff. So keep in mind that 2 exceptions, and you should manage the COVID-19 patient on steroid and hyperglycemia in the same way you manage other patients. That's the expert opinion from up to date. Now, before I proceed with the actual presentation, so I would like to invite one of my residents, Kai. She's an internal medicine resident in UCSF Fresno. She's going to present briefly over 5 minutes a sample case that will demonstrate the problem we encounter in the real-world situation. So Ika, are you ready?
Yes, I'm ready. Thank you, Dr. Nai.
So I'm going to stop my screen. Let me Let me stop my screen. Okay. Okay, all yours.
Okay. Slide 对呀 Yes.
တွေ့ရတယ်ဗျာ
Okay.
Okay now.
Okay. So this is a presentation on COVID-19 and diabetes. So there is an 84-year-old male presenting with altered mental status. He has a history of hypertension, hyperlipidemia, and type 2 diabetes. He presented with altered mental status for 3 days, and per his family was very lethargic each day. On admission, he was found to be COVID positive, and he was admitted to the ICU for acute hypoxemic respiratory failure, was intubated, placed on mechanical ventilator, and also started on dexamethasone 6 milligrams IV daily since that day of admission. So here is his home diabetes medication regimen. He takes glargine 10 units nightly and glimepiride 4 milligrams twice daily. And here are more of the pertinent labs on admission. CBC was normal, but you can see the glucose was elevated 474, bicarb 16, anion gap 16, and beta hydroxybutyrate also was 13.7. BUN 63, creatinine 2, and GFR was low at 32. The hemoglobin A1C that we checked was 10.5. And on the ABG, pH was also decreased at 7.25. So due to initially having DKA, the patient was placed on an insulin drip for 12 hours, requiring an average of 12 units of insulin an hour, and afterwards was transitioned to subcutaneous insulin. So this is a chart that shows the patient's glucose over the course of the hospital stay. You can see the different glucose values listed here. Underneath that, the dose and the rate, this is the insulin drip. And at the very bottom was when they were transitioned to subcutaneous insulin with glargine and regular insulin. So you can see that for the first 12 hours, the glucose was initially in the 400s and they were on the insulin drip. And then the glucose came down to 107. After that, when they switched to subcutaneous, they were doing insulin glargine 10 units with sliding scale of the regular insulin. It wasn't controlling the sugars very well. They were going back up into the 300s. So they went up to insulin 20 units nightly, still did not control the sugars very well. And they went up to insulin glargine 30 units nightly. Even with that, the sugar was still elevated up to 365. And you can see here on the very last day, actually, the patient became very hypoglycemic. It dropped to 78. So it was very labile. Unfortunately, this patient did continue to worsen. He was transitioned to comfort care by his family, and he did eventually pass away. So there's 2 key learning points that I wanted to make from this case. Number 1 is that this patient had severe insulin resistance, requiring up to 12 units of insulin per hour while on the drip. This can be due to 2 factors, since dexamethasone use can itself lead to increased insulin resistance. And then COVID-19 also has been associated with worsening hyperglycemia and insulin resistance as well. The second point is that we tend to avoid hourly glucose testing in COVID patients in our hospital, if possible, to decrease nursing exposure. So we kept the patient on the drip for 12 hours, but after that switched to subcutaneous insulin as soon as the DKA resolved. This is just a quick picture of the order set that we use in our hospital for DKA insulin infusion. Our target is a blood glucose of 150 to 200 until there's resolution of the DKA. And these numbers here just show how the nurses already have a preformed order set on how to adjust the drip according to the blood glucose that they check every hour. So if the glucose is between 70 to 149, they can decrease the drip by multiplying by 0.5. If it's between 150 to 200, they adjust it according to what's written here as well. And if the glucose is greater than 200, then depending on what the previous rate was an hour ago, they will adjust it accordingly. We also have another insulin infusion order set, but this is for non-DKA patients with just hyperglycemia that's difficult to control on subcutaneous insulin. So for this, we usually have the nurses check the glucose every hour, but if the glucose has been stable for 3 hours, then we decrease the checks to every 2 hours and then eventually every 3 hours. And then the goal here is slightly different from DKA. The goal is from around 80 to 140 is what we use here. So you can see that if the glucose is 70 to 89, then you would stop the insulin infusion. But if it's between 90 to 120, then you would decrease the infusion rate. If it's between 120 to 180, which is around what you'd want when you're in the hospital, then there's no change to the rate. But if it is greater than 180, then you would increase the rate. All right, thank you.
Thank you so much for a very comprehensive presentation. Keep sharing here, Dr. Kai.
Okay. Can you see my slide now?
Not the slide, sir.
No slide. Okay. How about now?
Yeah, now we can see the slides there.
Okay, thank you. Okay. Now as it kind of demonstrated that it's very challenging to manage hyperglycemia in COVID patient on dexamethasone. So dexamethasone steroid can give you severe hyperglycemia and two mechanisms. If you get glucocorticoid, which is dexamethasone and prednisone, and it will decrease insulin secretion from beta cells. And therefore, the medication choice is probably one of those, a combination of insulin secretagogues, such as sulfonylurea, and GLP-1 based therapies, such as DPP-4 inhibitor and SGLT2 not SGLT2, sorry, GLP-1 receptor agonist, maybe an appropriate choices. Now, similarly, that increase your insulin resistance, and therefore insulin, the medication that improve insulin sensitivity, such as metformin, and may be useful in management. Now, mechanism and effect of glucocorticoid and glucose metabolism. So it increases insulin resistance and decrease beta cell function, as I said before. And there are a few things you need to keep in mind in management of steroid-induced hyperglycemia in general. This mainly postprandial hyperglycemia and which is usually more severe than fasting. However, that depends on the dosing frequency and how long you give it. For instance, so typical patients, I think about a patient on prednisone, 60 milligrams once a day for a short period of time. So mainly they have a postprandial hyperglycemia. if you give twice daily prednisone or longer acting steroids such as dexamethasone, you could also have a fasting hyperglycemia. And similarly, accumulated dosing can have increasing hyperglycemic effect. For instance, if you give a steroid even short-acting longer duration of time, that you may begin to see fasting hyperglycemia in addition to postprandial. So in the beginning, with a short-acting, so mainly it's a postprandial hyperglycemia. So it's very important to remember. So postprandial hyperglycemia, usually after lunch and before dinner, is a time they get maximum effect from steroid. That's an area we need to monitor, we need to focus. Fasting hyperglycemia might initially, again, more severe with longer acting steroid, frequent steroid dosing, and prolonged use of steroid. And then later on, you need to focus on fasting hyperglycemia as well. This is these are the commonly used steroid in general practice. I'm going to focus on prednisone and dexamethasone because this talk is for the COVID. We use dexamethasone. So dexamethasone, 0.75 milligram is equivalent dose of prednisone 5 milligram in terms of that glucocorticoid activity. Now, in COVID-19 patient, we use dexamethasone 6 milligram. So we need to remember the number. Dexamethasone 6 milligram is about equivalent dose of prednisone 40 milligram. So two things you need to remember for this talk. So dexamethasone 6 milligram or prednisone 40 milligram at the same potency in terms of glucocorticoid activity or effect on hyperglycemia. Now, so for those, I don't know who, so the participants of which country they are from. So I know mainly from Myanmar. So if you are using millimole per liter, so 10 millimole per liter is about 180 milligram per deciliter. So you can convert that one. So if your country using millimole per liter, 180 is the same as 10 millimole per liter. Now, we are focused on prednisone and dexamethasone only for this talk. So, so that slide show hyperglycemic effect, and the onset is about 4 hours. Doesn't matter which one you use. Peak prednisone is about 8 hours. Hyperglycemic effect, dexamethasone, we don't know, but duration of action, prednisone is only about 12 to 16 hours, only half day, and whereas dexamethasone could last as long as 1 to 2 days. Now, to give you a perspective, so how we manage and steroid-induced hyperglycemia in the hospital setting, I'll give you an example. This is a guideline from California Diabetes and Pregnancy Program. There's a guide for the physicians. We still use it. So patient with premature contraction or labor, patient with diabetes or insulin, when they are admitted to the OB ward, we give betamethasone or dexamethasone 12 milligram, which is twice higher than the dose you use in COVID-19 patients. So when they are admitted, as you know, so the OB patient, pregnant patient on insulin, they are already on huge amount of insulin at baseline. So, so in America, so with obesity, usually they're taking, 50 units before each meal, 150 units of glargine at night. So they are on large quantity of insulin at baseline already when they are admitted for premature labor. And then on top of that, we give them dexamethasone or betamethasone 12 milligram once a day for 2 days in a row. Usually their blood glucose levels skyrocketed over 400, 500, 600. So to prevent the severe hyperglycemia induced by steroid, so that's a protocol we use. So day 1 and day 2, when they receive steroid large quantity, we double the insulin. Whatever they are taking, we double it. In other words, we give 100% of pre-steroid dose. And that day 2 and day 3 and day 4, they don't receive any more steroid, but that is a long-acting dexamethasone, and therefore dexamethasone half-life is at 24 to 40 hours. So next 2 days, we cut the insulin. We give only 50% additional dose of pre-steroid insulin. And then day number 5, 3 days after last dose of dexamethasone, and then they go back to pre-steroid dose. So that's a protocol we use. As you can see, we use large increase in insulin dose to control post-ME hyperglycemia and steroid-induced hyperglycemia. So you have to use that knowledge in the management of steroid-induced hyperglycemia in non-pregnant patients, as well as the patient with COVID-19 on dexamethasone. And this is a hospital, the management, and also don't forget pregnancy is a severe state of the insulin resistance. So they require that much. We increase by 100%. So this is 16 milligram of dexamethasone or betamethasone. No, you will be using only 6 milligram of dexamethasone or 40 milligram of prednisone. So increase in insulin amount is probably 50% from the pre-steroid dose, maybe an appropriate or maybe a conservative dose, 50% increase from the baseline. If you are patient on dexamethasone 6 milligram or prednisone 40 milligram. Now, these are the insulin available to manage patients in general population. So maybe, depending on which country you are, depending on the patient, and then hospital, and you can use any of those insulin to manage. I want to focus on MPH insulin that we will talk a lot later on. So MPH insulin, if you look at the screen at the bottom left picture, the left bottom picture is a MPH insulin. So onset is about 1 hour, peak is about 6 to 8 hours. It lasts for about half a day. Now, what is the preferred insulin for steroid-induced diabetes? So we are staying in the general population and general management. So could you be in your clinic, could be in the hospital setting. We are not getting into COVID yet. So steroid-induced diabetes, the duration of action of MPH closely mimics that of steroid, especially prednisone. MPH insulin peak at the same time that prednisone causes highest degree of hyperglycemia. As I told you in the beginning, if you give 1 dose of prednisone, the peak hyperglycemic effect is about 6 hours after dosing. If you get MPH at the same time, simultaneously, the MPH peak comes at the same time as steroid prednisone, and therefore MPH is a logical choice for your patient. Steroid-induced hyperglycemia, if you are using prednisone once a day in the morning, give it together. Now, why you prefer MPH insulin? Well, it's simple, only once daily dosing and elimination of methyl insulin because it has a peak, and therefore you may not need methyl insulin. And if you compare with glargine, some studies show that no difference with glargine, and obviously lower cost for most patients and most countries. Now, in general, how do you initiate insulin? This is how we calculate starting dose of insulin in general population. It could be outpatient, could be inpatient. We calculate basal insulin as 0.2 unit per kilogram body weight. Prandial insulin 0.1 unit per kilogram body weight per meal, and each meal, and it's a starting dose. And then we adjust the dose by 10 to 20% frequently. In a hospital setting, you adjust every day. In the clinic, every week, every 2 weeks, depending on how soon you can see patient, how soon you can accommodate patient. Now we're focused on basal insulin, outpatient setting without COVID, without being on steroid. We start with 0.2 unit per kilogram body weight. Obviously, patient on steroid may need higher starting dose. You may need more than 0.1 unit per kilogram body weight starting dose. So when you look at it, you will notice it based on the weight. So the heavier you are, the higher insulin dose you will need. So we don't give one size fit all for all patients. If you are slim, if you are thin, you will get smaller dose. If you are obese, severely obese, and then you will get higher dose. So why is that weight based? Don't forget, insulin resistance has a linear relationship with body weight. In other words, the heavier you are, the higher your insulin resistance is, and the higher dose of insulin you will require. And therefore, it makes sense to use the weight-based insulin dosing. Now, we have several, I think more than 10, 20 different methods to manage steroid-induced hyperglycemia. So I selected 4 examples that I think is simple to understand and follow. So I'm going to give you 4 different methods, and then you can use one of them, or you can modify, or you can combine depending on how you want to use it. I'm going to give you these examples. So method number 1, how do you initiate insulin? Well, again, weight-based, and we will use MPH insulin. And depending on steroid dose, every 10 milligram prednisone, which is about 1.5 milligram dexamethasone, you give 0.1 unit per kilogram the body weight of insulin with a maximum of 0.4 units per kilogram body weight. I'll give you an example. So we use a 6 milligram dexamethasone in COVID patient, which is equivalent dose of 40 milligram prednisone. So you initiate patient on 0.5 unit per kilogram body weight. So if your patient 50 kilogram or 110 pound body weight, you're going to initiate 20 units of MPH. If it's a once daily prednisone, you can give at the same time in the morning with prednisone, 1 dose. If it's a twice daily prednisone or dexamethasone in COVID patient, maybe twice daily, because dexamethasone has longer duration. So twice daily, and you split it into 2/3 in the morning and 1/3 in the afternoon. So 20 unit, maybe about 12 with the breakfast, maybe another 6 with the dinner time. So that's how you calculate the starting dose. Well, starting dose may not work at all on most patients. You need to adjust 10 to 20% every day. And if his sugar doesn't change next day, and you can increase even more than 10, 20%, depending on your experience with the insulin use. Now, there's an example how you calculate. So we already talked about it. So method number 2 is a little bit complex, but if it's something you want to use it, you can use it too. And that is proposed by the International Diabetes Center from Minnesota in US, that depending on the dose you go to initiate, you have a different dosing. It's not really weight-based, it's a fixed dose to make it easier for you. So for COVID patients, 6 milligram dexamethasone. So you may want to focus on the right side of column on the right side of the picture. So 6 milligram dexamethasone a day. Without diabetes, you initiate 10 units of MPH in the morning. So if it's type 2 diabetes or pre-existing diabetes, you start with 20 units of MPH insulin. If you use a weight-based calculation as a method, once you will find that you will have a similar dose. Weight-based calculation will give you very similar dose. So without diabetes, they want it to be more conservative, half of the calculated dose, 10 units. And type 2 diabetes, pre-existing diabetes, 20 units. Every patient, 10 units for without diabetes, 20 units for a patient with pre-existing diabetes. And again, if it's a prednisone in the morning, if it's a prednisone twice daily, or dexamethasone twice daily, maybe 2/3 in the morning, 1/3 in the afternoon. And now, how do you titrate? That they give you a detailed instruction on how you titrate. So when you look at the first column, increase MPH dose by 25% every day. So they are a little bit more aggressive in adjusting the dose. If your sugar number, at least one number more than 300 following day, you increase the dose by up to 50%. Similarly, if the patient getting hypoglycemia, you cut the insulin dose based on how severe hypoglycemia was. And it will give you detailed instruction on how you taper off. So that one is it look complex, but when you look at it, it gives you more detailed instruction on how you increase, how you decrease, how you taper off. So if you prefer that one, so this is another method, you can use it. And the third method is also I will show you only two different steroid, prednisone and dexamethasone. So the prednisone, if you use every day in the morning, MBH 0.5 unit per milligram, and prednisone. So it's not weight-based, it's based on the prednisone dose. So 0.5 units of MBH per milligram of prednisone. If you give 10 milligram prednisone, you give 5 units. So as you can calculate, if you give twice daily prednisone, you use twice daily MBH. Now we're focused on dexamethasone 6 milligram. If you get dexamethasone and 3 units per milligram, we normally get 6 milligram dexamethasone in COVID patients. So 6 milligram means about 18 units, very similar to previous, the method 1 and 2, you come up with about 20 units of, MBH. Doesn't matter which method you use, you will come up with approximately 20 units of MBH insulin in the morning. Or if you want to split it at 12 in the morning, 6 in the afternoon, doesn't matter which method you use. How about the basal bolus insulin? If you are already on basal prandial insulin at home, you increase by about 50%. So we talk about it in the beginning. So pregnant patient, dexamethasone 12 milligram, we increase by 100%. So now we use 6 milligram dexamethasone in COVID patients, and we increase by about 50%. So you increase about 50% of a home basal prandial insulin dose. And don't forget, those patients mainly postprandial, so you increase more with the prandial insulin and during the daytime. So the ratio should be about 70% during daytime for the mean and 30% as a basal insulin. We normally use 50% ratio for basal and prandial in non-COVID, the patient not on steroid. So once you are on a steroid, your ratio should be 30% basal, 70% prandial insulin. Since usually postprandial hyperglycemia is more severe than fasting hyperglycemia. So now we're going to move on to method 4. So I promise that this is the last method I'm going to show you. So if I show all the 20 methods, you will get absolutely confused. So I find that 4 methods are kind of simple to use, and then in the real world, easy to follow. So method number 4 is actually guideline from UK. So colleagues from UK may be familiar with this one. In fact, this is the only guideline in the literature, the national guideline for steroid-induced hyperglycemia. So you can go and look at, it's published in Diabetic Medicine a while ago, I think about 6 years ago. You can look at the detail. So that's both the oral and insulin therapy. So you check the blood glucose at least 2-3 times a day. If your blood glucose is over 10 or 12 millimole per liter, which is about over 200 milligram per deciliter, and you activate the treatment. So what treatment means? That treatment could be oral agent or insulin. If you want to use oral agent, so gliclazide. So different countries use a different the sulfonylurea. In America, glycoside is not available. So we use glyphosate. Similarly, in UK and Myanmar, I don't think glyphosate is available. So you use glymeperide or glycoside. At the bottom of the slide, you can see the conversion table. So glycoside 40 milligram or glyphosate 5 milligram in the morning, with the steroid. Why not in the afternoon? As I said before, initially, especially with once daily prednisone, the most severe hyperglycemia is about the after lunch or before dinner, and during the daytime and post meal. So if you give one dose in the morning, it's usually covered during daytime, and you may not need at dinner time. So we give once a day in the morning. It doesn't work, we can double it from 40 glycoside to 80 or glyphosate 5 to 10 next day if so if your blood glucose stay high. And it doesn't work, you can include afternoon dose, especially if fasting blood glucose getting higher, up to maximum dose of 240. It doesn't work, and then you can move on to insulin. Now, how about patient with a known diabetes on once daily steroid? We're talking about prednisone. Don't forget, the patient with COVID, we use dexamethasone, and you have to use twice daily insulin, 2/3 in the morning, 1/3 in the evening. So keep in mind. So if you want to use oral agent, it's okay. If your blood glucose is not severely elevated, you can use the same way glycoside or glyphosate in the morning, and it doesn't work twice daily for COVID patient. Twice daily, maybe dexamethasone twice daily may be more appropriate choice. So if you have to use insulin, especially those with severe hyperglycemia, if patient already on once daily nighttime insulin, move it to daytime insulin. One method is, for instance, I'll give you an example. If you are patient MPH nighttime, move it to daytime. And if you are patient glargine or longer acting at nighttime, one approach is keep them on glargine current dose and add MPH in the morning. So you may be taking two different kind of insulin, but the good thing about that is you don't need to keep switching back and forth, Lantus to glargine to MPH and MPH to glargine. So you keep glargine at night, no change, same dose, and you add MPH in the morning as long as patient on and steroid. And then once patient, steroid discontinue, you can discontinue MPH. Once you cut the steroid dose, and then you can keep cutting MPH dose in the morning, so without needing to adjust the glargine at night. So one option is keep glargine as it is, just throw in MPH in the morning. Or if you want to switch completely to MPH, that's okay. You can combine current basal insulin plus additional requirement. It's up to you. If patient on twice daily insulin, could be MPH twice daily or premix 70/30 twice daily, and you increase morning dose to begin with. Again, I need to emphasize it's mainly postprandial problem in the beginning. You keep adjusting morning dose until you get a target. Later on with, the frequent dosing and prolonged duration of a steroid use, you may need to adjust afternoon dose at all, but you start with always morning dose. And what if a patient on basal-prandial insulin, or if patient already on basal-prandial insulin, depending on the dose, in COVID patient, we will increase by about, as high as 50% initially. But now this is not COVID patient, so that protocol. So they want to be a bit more conservative. So they advise you to increase by 10-20% every day. So if you want to be more aggressive, increase up to 50% from day one. If you want to be more conservative, you increase about 20% every day, depending on your experience level, and then also depending on how aggressive, conservative you want it to be. For instance, if you are the house staff, residents, the junior faculty, not much experience in insulin dosing in steroid, you may want to be more conservative, so you can increase basal prandial insulin dose by 10-20% every day. If you are kind of, very experienced physician, diabetes specialist, and then you can go up to 40-50% from day one, depending on your experience level and then your comfort level and how aggressive you want to deal with it. And also, of course, depending on how severe current hyperglycemia is, if your sugar running 600, 500, maybe 40-50% increase will be a right, kind of approach. If your sugar is running just over 200, then maybe 10-20% increase will be most appropriate. Now, overall treatment recommendation from that baseline, and then again, I'm repeating, MPH insulin is preferred insulin, MPH insulin added to current diabetes regimen, could be outpatient or basal bolus inpatient. Basal bolus, if you use it, 30-70 ratio, 30% basal, 70% prandial, and more aggressive, the correction scale or sliding scale insulin you can add into it. So insulin pump is not relevant for this talk. We're going to skip insulin pump. So this is a guideline. So the one published about 6 years ago. I find it very simple to use. So I modify a little bit, and then I'm going to show you this slide. So this slide is quite busy. So I'm going to show you top the algorithm only and next page. So this is can you read it or it's too small?
For me, I can read it because I can zoom in on my tablet.
Okay. So if you are using cell phone, maybe too small. If you are using computer screen, you can read it. So top row is the first step is actually this is a patient who are not treated with insulin. So I'm going to show you two different slides. One is the patient not treated with insulin. So could be type 2 diabetes or oral agent, could be not known to have diabetes and simply just steroid-induced hyperglycemia, could be type 2 diabetes on diet only. So if the patient not on insulin, patient started on steroid, how do you approach it? Well, obviously you don't want to give insulin or any medication right away. You want to monitor, so to see if they really need to be on additional therapy. So what you need to do is just ask them to test blood glucose. How often they should be testing? Well, if they can test it 7 times a day, even better. If they cannot test it, minimum requirement is the twice daily or once daily. The best timing is a pre-dinner, and or 1 hour after lunch. This is where you have a maximum impact from the prednisone dose or dexamethasone. Now, if pre-dinner blood glucose over 140, or you can set any number you desire. For instance, if you want to be very conservative, I don't want to treat unless pre-dinner or pre-meal blood glucose more than 180, you can set it to 180. And now after lunch, more than 200, or again, you can set it to 250 if you want. So this is just guide. So if the glucose reading at least 2 times over your target, you activate the treatment plan. So treatment plan depends on how severe hyperglycemia is. So for instance, before dinner, before meal is less than 200, yeah, you can try oral hypoglycemic agents, one or combination. The best one is insulin secretagogues, so such as glipizide, gliclazide. Now, if you want to add metformin, you can add metformin. If the patient already on metformin, you want to keep metformin as long as patient not losing weight, no patient throwing up. Obviously, you should not be using metformin. And then DPP4 inhibitor can also stimulate beta cell to make some insulin. It may be another choice. Some study, small studies show that DPP4 inhibitor improve survival in COVID-19 patient, but that is small study, a retrospective study. But it's an option if you want to use oral agent only. So If it's not controlled after a couple of days, 2-3 days, you can switch to insulin therapy. So we're going to move to the middle column, which is blood glucose more than 200 before dinner or severe hyperglycemia. You should initiate insulin and weight-based MPH in the morning with or without or a hypoglycemic agent. And now you can increase by 10 to 20% every day to achieve a pre-dinner and target you desire. If any number over 300 next day, obviously the amount you give is not enough. So you want to increase by as much as 50% next day instead of 10%. So what if patient, now we're going to move to the last column on the slides. If the patient, if you want to use twice daily MBH for COVID patient on dexamethasone, you use twice daily, 2/3 before breakfast, 1/3 before dinner. And again, you can increase by 10 to 20% every day or up to 50% if blood glucose over 300 next day. Now that slide is busy and I try to keep it simpler. So the patient on insulin already. So I think since we are running out of time, I want to, I will make a slide available if you want. So you can read it. So I'm going to give you example. We're going to focus on the right side of the column. So which is for the dexamethasone because this is a COVID-19 dexamethasone talk. So I'm going to focus on patient on dexamethasone. So focus on the right side of the column within the dotted line. So if the patient on dexamethasone in COVID patient, if the patient already on MPH insulin at night, and then just switch it to in the morning, or split it into 2/3 in the morning and 1/3 in the afternoon. What if patient on glargine? You can simply increase glargine at night. What if patient on twice daily 70/30 or MPH twice daily, and you can increase the insulin based on the weight-based calculation and 2/3 in the morning, 1/3 in the afternoon. Basal-prandial insulin, patient already on basal-prandial insulin, so you can add additional insulin and make sure you have 70% bolus, 30% basal, and you increase 10 to 20% every day. Now we're going to move to COVID-19 patient and hyperglycemia management, not including, so we are not into that dexamethasone and COVID-19 patient yet. We are now moving to hyperglycemia in COVID-19 patient in general. So glycemic target in COVID-19 cases, again, there's not the evidence-based medicine. There's no study done on COVID-19 patient in diabetes. So up to date recommended that we use the same target for the non-COVID patients. So your glycemic target should be 140 to 180. And so type 2 diabetes patient with COVID eating normal diet, mild to moderate, COVID without dexamethasone therapy, and you can continue same medication, home medication. That medication you would like to avoid in those patients. Any patient who are sick in the hospital is SGLT2 inhibitor because with the calorie restriction, patient may develop DKA. So you may not want to continue SGLT2 inhibitor in any sick hospitalized patient. Of course, a patient throwing up, very sick, not eating well, you may not want to continue metformin. If they look reasonably well, you may want to continue the other home medications such as DPP4 inhibitor, GLP-1 receptor agonist, including metformin, if you think they can continue. If glucose levels are very high, or if you initiate dexamethasone, and then you have to move on to insulin therapy. How about type 1 diabetes eating normal COVID patient, mild to moderate COVID-19 without dexamethasone, continue home dose insulin. If you initiate dexamethasone and you add additional 20-30% and adjustment 10-20% daily. How about DKA? I want to spend about 5 minutes on that. So I don't know how many hospitalists or ICU, the physician in this group, if you are working mostly as an outpatient, it's not going to be relevant for you. You can forget it. If you are working in a hospital setting and dealing with a COVID patient, that may be helpful. So as I said before, COVID-19 patient may present with DKA or HHS or severe hyperglycemia. Could be because of COVID, could be because of steroid. How are we going to manage? Well, keep in mind that you don't want frequent visit into the patient room or yourself or your staff. So you're going to expose to COVID-19. So you want, less frequent visit. At the same time, you need to provide a quality of care. Ideally, insulin infusion is the best, but it's not practical in COVID-19 patient. Now, again, we don't have national protocol, and we have protocol from different university hospital. So I'm going to show you a subsequent slide. So what kind of protocol they are using, and then you can look at it and you can modify it to your hospital if you want. So now mild to moderate DKA or HHS in COVID patient can be managed with subcutaneous insulin rather than intravenous insulin infusion, and that require your staff to be exposed to COVID-19 patient only every 2 to 4 hours instead of every hour. So what do you mean by mild to moderate DKA? So that is the ADA, the definition. So if you look at the middle column, I put it in the red color box. So if pH is more than 7 and pine cup is more than 10, patient conscious a lot, you may use subcutaneous DKA protocol. Now, so these are the protocol available. So ADA website, I showed you the link. You can get in and you can look at each individual protocol in detail. So we don't have enough time to go over each protocol. So if you are interested, if you work in hospital, please get it and look at it and then come up with your own protocol that you can use it in your own hospital. So they are using in the university hospital with large number of patients. So I consider it safe and effective. You may want to use one of those or combination. So I'm going to give you one example. This is a Mount Sinai Hospital. So the subcutaneous insulin protocol for DKA and severe hyperglycemic patients. And at the top is the link. So it's a Mount Sinai Hospital from New York. So if you look at that, the subcutaneous insulin protocol within the regular box. So they give a first dose of glargine and lispro based on the body weight, again, based on body weight. So glargine 0.2 unit per kilogram body weight and lispro 0.2 unit per kilogram body weight. The stat dose and followed by every 3 hours, they give insulin amount based on the change in the glucose at the previous hours. So you require to get into patient room every 3 hours only. That's one of the example. It's quite simple to follow. I'm sure it's a pretty safe because they've been using it in the university, a large university hospital for a while now. Now, finally, I have about 4 slides left. And now we're going to put all together what we learned. So we learned how to manage in general population, steroid-induced hyperglycemia. We learn how to manage diabetes in COVID-19 patient. Now we're going to put all together, and now I need to make it clear. I'm not, I don't think anyone is expert in management of, steroid-induced hyperglycemia in COVID-19 patient on dexamethasone. Again, I'm sharing my experience. So as I said before, I had a symposium last week with the University of Medicine Mandalay and University of Medicine McGuay, and we share our experience. I learned a lot from them also. So I listened their challenges, how they treat. I learned a lot from them too. So we'll do the same thing at the end. So I'll be happy to share information and learn from you as well, how you manage. This is a suggested. So we put together what we learned over past hour. So now for dexamethasone-induced hyperglycemia without previous history of diabetes, what could be newly diagnosed diabetes that you don't know. How do you know newly diagnosed diabetes? check A1C, A1C 10% on admission, that is pre-existing diabetes, undiagnosed diabetes, you just pick up. So how about A1C come back normal and newly diagnosed diabetes, probably COVID-19 induced new onset diabetes. We talked about it in the beginning. Nobody know pathophysiology, nobody know what it is. You know, new onset, is it type 1, type 2? Nobody know at this time. Could be pre-existing diabetes, newly diagnosed, we never diagnosed before. Could be new onset diabetes induced by COVID-19. Could be just glucose intolerance. So whatever the reason, a patient coming without history of diabetes and then sugar elevated on admission. And if sugars are running crazy high on admission, you may not want to just keep monitoring for 2-3 days. You want to initiate therapy from day one. If sugar number are barely elevated or normal, and you put the patient on dexamethasone, and you want to monitor, as I said before, if you want to monitor those kind of patients without previous history of diabetes, sugar look normal on admission, the best timing is pre-dinner and or 1 hour post-lunch. So you can monitor those patients. So now if you want to initiate therapy, 2 options, either oral agent or insulin. It depends on your preference, patient preference, and also how severe hyperglycemia is. So if any number over 200 time to within past 24 hours, you should probably initiate therapy. So the blood glucose 200 is kind of, again, you can set your own number, 180, 250, depending on your preference. So now, of course, the inpatient setting, sulfonylurea with or without DPP4 inhibitor and metformin for my hyperglycemia is option if you think it's appropriate. So we prefer, however, insulin for inpatients. It's much easier to manage, more control over, medication dose. So moderate to severe hyperglycemia or very high on admission or is uncontrolled on sulfonylurea, you initiate MPH, the same dose calculation we learned over past 1 hour. So you give fixed dose 10 units for without history of diabetes. You will remember we give 20 units for history of diabetes or weight-based and 2 divided doses. Why 2 divided doses? Is because it's a dexamethasone long-acting insulin, 2/3 in the morning, 1/3 in the evening. So 0.2 to 0.3 unit per kilogram body weight for 6 milligram dexamethasone. So now it's a more conservative dose for patients without history of diabetes. With the history of diabetes, we use 0.4 unit per kilogram body weight. Without history of diabetes, we want to be a bit more conservative, half a dose we start. Now, what if patient type 2 diabetes coming on oral agent? Well, again, if the patient doing well, no contraindication, you can continue whatever oral agent patient on it. Patient on diet only, or patient non-type 2 diabetes, not taking medicine, or patient on only 1 oral agent. If you want to initiate, sulfonylurea, again, is a drug of choice. You can add to the current regimen. If the patient sick, patient severe hyperglycemia, and you initiate MPH now, non-diabetes, we give 20 units or 0.4 unit per kilogram body weight, 2 divided dose, again, 2/3 in the morning, 1/3 in the afternoon. You increase by 10 to 20% daily, or up to 50% if blood glucose 300, if you want to initiate basal-prandial insulin, don't forget 30-70 ratio. Now, how about patient on insulin? The same thing. On basal insulin, nighttime switch to AM insulin. If the patient on twice daily insulin, you increase morning insulin first, and then subsequently you can increase also evening insulin if fasting blood glucose elevated. How about at home basal-prandial insulin already on it 4 times a day? Increased by about 20% in type 1. So you'll be more conservative with type 1. Type 2 diabetes up to 30-40% or even 50%. And then increase by 10 to 20% ratio, keeping 30 to 70% ratio all the time. Now, how about DKA, HHS, and COVID patient on dexamethasone? Mild to moderate subcutaneous insulin protocol. We talk about it. Severe DKA where you have to use the usual care with insulin infusion as demonstrated by AKI. Initially patient unconscious, patient in renal failure, and then the DKA. So we use insulin infusion to get it down. As soon as it's kind of mild to moderate DKA range, we switch quickly to subcutaneous insulin protocol by using one of those protocol I mentioned. So that's the end of my talk. And I think I have another 5 minutes. So I'm not sure how many of you are mainly outpatient based. So how many of you are inpatient? So for those who doing exclusively outpatient, so I want to show you very last slides, and I promise no more slide after that. So if you ask me, you talk about Dr. Nine, dexamethasone, inpatient COVID. So as an outpatient physician, I don't deal with COVID inpatient. Can you give me one slide that I can use it for my inpatient, outpatient on steroid? So outpatient setting, patient on steroid, mostly on prednisone for asthma, rheumatoid, for whatever reason, flare up for inflammatory bowel syndrome. We use 30 to 60 milligram of prednisone in the morning, and maybe patient coming in chemotherapy, and they give dexamethasone 12 milligram one dose for 5 days during chemotherapy. I have numerous consultation asking, my patient sugar running over 500 with the chemotherapy and dexamethasone. How do we manage? So the very last slide. So I give my patient, again, this is my, kind of own the guide. So you may want to tweak, you want to use it for your own patient, you want to modify, it's up to you. I'm going to share my experience. It works well, so patients self-adjusted. So I give this one, a patient keep it every time patient on steroid course, they use it and they don't need to call me back. And they normally have a pretty decent control. Now, don't forget, steroid-induced hyperglycemia, we talk about a lot on how to increase, how to adjust. Please don't forget, when you wean off, taper off, you need to decrease insulin. If you don't do that, your patient will be in ER with hypoglycemia. So by using self-adjusted, self-titrated protocol, patient increase and decrease based on a steroid dose, and they don't get hypoglycemia. So if the physician adjusted insulin regimen for the outpatient setting, one problem is you increase it, you don't know when that you are rheumatologist or chest specialist going to do a steroid. Don't tell you they will take off the patient steroid, they will taper off. Next thing you know is patients start having hypoglycemia. So by using patient self-titrated regimen, and you can eliminate that risk. Patients stop, patient know they have to stop that insulin, or they need to and that decrease the insulin. This is the final slide. Again, this has nothing to do with COVID, nothing to do with hospital. It's outpatient exclusively. Patient require frequent steroid dosing at home. So what you need to do is, now, of course, the patient, the patient not on insulin, so I give, the sulfonylurea in the morning. So patient on insulin, that is a patient self-titration protocol. So they calculate 10% of current insulin doses. I call it a pre-steroid insulin dose for each injection. Patient on full shot day, you calculate pre-steroid insulin dose for each injection. And then that 10% is your default. And now each 10 milligram prednisone or 3 milligram of the dexamethasone, patient at 10 units of pre-steroid dose. For instance, if the patient get a phone call from chest physician, you start taking 60 milligram of prednisone, patient know what to do. Patient at 60% additional insulin dose for each dose of insulin. And so when they taper off each 10 milligram decrease in prednisone, they taper off by 10%. So in other words, if the patient, if a chest physician call patient, you know what, cut the prednisone dose to 30 milligrams tomorrow. Patient know what to do exactly. Patient will cut 30% of insulin and patient will be safe. Similarly, patient next day stop completely and patient will go back to pre-steroid dose. So by using that, your patient can adjust the insulin dose up and down. And don't forget, nighttime insulin, you need to be careful, basal insulin, because the steroid-induced hyperglycemia is mostly post-meal, daytime. So nighttime insulin, you need to be more conservative, and you may want to use only 50% increasement instead of 10% increasement, especially smaller dose of steroid, once daily prednisone, and shorter duration. Instead of 10% increasement, you may want to use only 5% increasement at the basal insulin. You can write it down for the patient. You can create that table for the patient. Patients use that regimen at home, and then doesn't matter how long they need steroid, what kind of steroid, they can safely adjust the insulin at home, and they don't need to call you for, otherwise you will get a phone call, my sugar 500 and now my sugar 50. So with that, self-patient adjust that protocol, and you don't need to test for the outpatient, nothing to do with COVID. So I'm going to conclude my talk, and then I will be happy to take the question, or I will be keen to learn your experience, COVID-19 patient and steroids in your country or in your area. Thank you.
Okay, မိကုန်းမေးတာတော့ဆရာကြီးနဲ့ဆွေးနွေးဖို့မိကုန်းမေးတာတော့ဆရာကြီးနဲ့ဆွေးနွေးတာလုပ်လို့ရပါပြီခင်ဗျာ Okay, ဆရာတန်းထွန်း
Hi. Thank you for your for sharing your the management of the hyperglycemia in the COVID patient. And thank you very much. Very appreciated, and that we get a lot of the information to control the hyperglycemia in the COVID-19. I have a few questions. In the case of the COVID-19 with this hyperglycemia. Number one is I would like to notice how many days we need to be monitor the patient without diabetes before. You said this we have to be monitor the patient with COVID-19 when before we start the dexamethasone, or we need to start the dexamethasone. So I would like to notice how many days we need to be monitor the patient with COVID-19 without history of the diabetes.
Actually, you don't need to monitor before you start dexamethasone. So you may need only one-time test and see if they have euglycemia or elevated blood glucose at baseline. I don't think you need to monitor. So for instance, you decide to start patient on dexamethasone, you can just test it like non-COVID patient. If their blood glucose is normal, and that's one time you need to say they are normal. So if their baseline unexpectedly over 300, and then you can initiate treatment. If there is euglycemia prior to one-time test, the before initiation of dexamethasone, of course you need to monitor. Those patients can get really serious hyperglycemia with dexamethasone, and then with the first dose of dexamethasone, you monitor at least one time a day, at least. before dinner or 1 hour post lunch on dexamethasone. Once you see the increase in blood glucose, you can monitor more frequently. So before dexamethasone, you don't need to monitor. You just want to find out what is the baseline blood glucose, one off, and you take it from there. Once you are on dexamethasone, at least one time, monitor every day, and more frequently if you think sugars are climbing up.
Thank you, Sian. And another one is as we noticed in a COVID patient is all the patient is doesn't do not need is dexamethasone, right? That depend on this the sign of maybe a symptom of the cytokine strongness that we add that is a steroid. So in those cases, we would like to notice the monitor of the do symptom is who will monitor is a do symptom is like a cytokine strong reaction or something is because I don't notice in the US it is who take care of the COVID-19 endocrinologist or is the general medicine. So for example, one I would like to notice who will start that dexamethasone is from the endocrinologist or is from the general physician in the COVID web.
Okay, so that's to begin with, so endocrinologists, they don't go and see patient in a hospital mostly, all right? So we are mainly outpatient. Yes, when we need to see inpatient, it also depends on hospital and country. In US, where I work, so we take care of patient with the endocrine emergency only. So, before COVID, say thyroid storm, say the myxedema, coma, a dystonia crisis, suspected new onset Addison disease, the kind of patient, hospitalist. We have a hospitalist who works exclusively in a hospital and they don't do clinic and they take care of all diabetic patients. Now, with the COVID-19 crisis, a COVID unit, they continue to take care of diabetic patients. Endocrinologists, we don't go and see patient. Pre-COVID, we don't. And then during COVID, we don't. However, if the patient has, unusual case, like kind of, euglycemic DKA, and they struggling to bring down the acidosis DKA, unusual cases, complicated cases, yes, we were, get involved, but we don't physically get into the room and see. We have a telemedicine, so we can do face-to-face with the referring physician, and we can communicate with the patient face-to-face or telephone. We have a telemedicine is so popular in US, so we can do telemedicine, without needing to get involved. Don't forget, in the beginning of COVID crisis, even in US, we had to use face mask, one face mask for 7 days in US. I used one face mask for 7 days, disposable face mask. In the beginning, we don't have PPE. We're trying to avoid frequent exposure or frequent use of a PPE to save PPE. So we were instructed to use telemedicine, so if possible not to get into the room. So we doing the same way. So who manage? Yeah, hospitalist or ICU team manage COVID patient, and they initiate dexamethasone and they discontinue dexamethasone. So we have, we involve in the unusual cases only, and only when we are needed, not routinely in our hospital. So maybe different. Some hospital, yes, they have an inpatient diabetes team by endocrinologist. Yeah, they will continue. We don't have inpatient diabetes team specifically, and that therefore we don't get involved unless this unusual case.
Thank you so much. Yeah, and also very appreciated sharing about challenge periods.
Any other question, or anyone want to share your experience?
Hello, sir. First of all, thank you so much for your very comprehensive and very complete package, right? And I got a question, sir. So let's say a patient got a hyperglycemic episode during COVID-19 period, during his illness. So at what timing, how do we or when should we recheck the glucose status to find out whether the patient ends up with diabetes mellitus or not?
Yeah, so the one patient present with hyperglycemia, so a few possibility especially on dexamethasone. So first question is it pre-existing diabetes? We miss it. This is a new presentation. Just easy check A1C. A1C is diabetic range. You have a pre-existing diabetes. Now A1C come back normal, so could be steroid-induced hyperglycemia, and that will resolve obviously once dexamethasone discontinue. So now how about new onset diabetes induced by COVID-19? So as I said in the beginning, nobody knows what it is. Is it type 1? Is it type 2? Is it transient? Is it permanent? Is going to persist? Nobody knows at this time. So only time course can tell you, for instance, patient come in normal A1C, and then new onset, hyperglycemia, and then patient survive, and you start dexamethasone, 6 weeks later, 3 months later down the line, patients still have a hyperglycemia. So maybe there's a COVID-19 induced new onset diabetes. At this time, we don't know what it is. That's why further research is needed. So now on admission, during admission on steroid frequent glucose testing, frequent means not really 7 times a day, at least 2-3 times a day, or 1 time a day pre-dinner. And then after discharge, you may want to follow them up, if they don't have still diabetes, just to make sure that the diabetes or hyperglycemia go away. So if it go away, you can conclude that it's a steroid-induced transient hyperglycemia. It doesn't go away, maybe COVID-19 induced new onset diabetes.
Thank you so much, sir.
Any question or anyone want to share your experience? I saw the Monzo in the beginning. I don't know if you are still there.
Yes, yeah, I'm me.
Okay.
Yeah.
So the UM2, I know. So how about experience from UM2?
Actually, we use the insulin, both basal bullet regimes, and sometimes twice daily, like MBH. It's okay, I think, yeah.
Okay, so that I think that's a good regimen, twice daily MBH. So I think most patients on COVID on dexamethasone twice daily MBH should be a good choice, and that should give you a pretty good control. Good. And do you use the oral agent at all?
Actually, in most of the hospitalized patients, we use is just insulin. Yeah.
Okay. Yeah, I think a good option. Thank you.
Another one is only oral medication is DPP4 inhibitor.
Oh, you use a DPP4 also? Okay. Okay. Yeah, this is another option. So you can use combination. So especially if you worry about post-me hyperglycemia together with MBH, so you can use. So in Mandalay University medicine, I think one suggested 70-30 insulin because the Myanmar people eat a lot of rice. The problem with dexamethasone is in Myanmar, management, we eat a lot of rice. I still do. So I'm sure most of your patients, eat rice a lot for breakfast, lunch, dinner. And dexamethasone increases the appetite. You put patient on insulin. Insulin increases appetite also. And your patient will be eating twice more than they used to at home. And they will be bringing food from home. And then it will be very challenging with, eating large quantity of carbohydrates. So sometimes maybe 70-30, that will cover post-meal better than MBH. So you can think about switching to 70-30 if you think patient eating a lot of carbohydrate or rice. And don't forget, you can use 70-30 up to 3 times daily before each meal. So if you plan to use 70-30 3 days before each meal, the ratio is usually half of the total dose for breakfast, usually a quarter at lunch, a quarter at dinner to prevent a nocturnal hypoglycemia. Usually we use 2/3 in the morning, 1/3 in the afternoon. If you do 3 times a day, sometimes 3 times a day works much better, but don't forget, it will be more frequent injection, and therefore, if you want to limit the frequency of injection 3 times a day, 4 times a day may not be a good idea. So, but if you want additional good control and you can commit 3 times a day injection, 70-30 3 times a day is a really good option. You can try it. It's a pretty good option. Thank you. So anyone from other country, anyone from other hospital,
Hello,
do you want to
Sia.
share your experience?
So yeah, I'm Janu.
Hello,
Sia.
yes.
Yes, I'm Janu, Sia. Now I'm in YGH, not only seeing the diabetes patient as well as the COVID positive cases. So,
okay.
and luckily, not like the doctors, endocrinologists in US, we are seeing the COVID cases. So
Okay,
what
so how
I
you
found is
manage?
that for the glycemic control, usually NPH once a day insulin is very good for the steroid-induced hyperglycemia. And what I found is that usually once a day is enough in most of the cases. Very few patients need twice daily NPH. If the glucose is very high, and for this case, we give the basal bolus injection. And the problem is that correction doses, we can't do the correction doses accurately because the injection are given by the nurses and the resident, so difficult to correct at the same time. So we need to schedule the insulin. And for the DKA and the HHS, we can manage with the VRII. And for the oral hypoglycemic drug, if the COVID is not very severe, category B, when their their oxygen requirement is decreasing, I put on the DPP4 inhibitors, and they are fairly controlled with such kind of OHA. And before they discharge, we add the metformin if they are tolerant and if they are not contraindicated.
Okay. So look like DPP4 is commonly used in Myanmar and also, around the world actually. So, DPP4 inhibitor used a lot especially in Asian country, actually, not Asian countries. So that was a paper from Italy not long time ago, and they look at the patient treated with DPP4 inhibitor. They found that it's a retrospective study, small number. So those patients do better than those who are not on DPP4 inhibitor. So don't forget, DPP4 inhibitor has a very mild anti-hyperglycemic effect. So I don't know, it should be used routinely in every patient because if your sugar is running crazy high, so it may not be a good choice. It won't work, that much. So maybe, the MPH insulin will be a first choice for the cost, also for potency. In some select patients, patient can't afford it, easily available, DPP4 inhibitor, maybe a good add-on therapy if you want to use it. But I don't think it will be initial. It will be a good initial therapy for most patients. Any other question or discussion? So if no further questions, I want to thank all the organizers and also all the participants. So stay safe and be healthy. Thank you.
Thank you, Sai.
I'm sorry, sir. I think my connection is a little bit unstable and I lost you sometime. So thank you so much for your time, kindness, and your effort. And I think I learned so many things from you, something like, how to initiate, how to commence insulin regime, and so many protocols. And the last thing is your last slide, which is pretty fantastic to me because, it's really comprehensive and they're handy to adjust their insulin for pregnancy low, which is really practical for me and it is really handy. So thank you so much, sir.
All right. Thanks again, everybody. Thank you. Have a good day. Or
Yeah,
have a good
have a
night,
good day, sir.
depending on where you live.
Bye-bye,
You too, Sai. Bye.
Thank you.
But ကျွန်တော်တခု request လုပ်ချင်တာဒီ form အဆင်ပြေလို့ရှိရင်လေဒီဟို survey form လေးတွေကိုဒီ chat box မှာပို့ထားတဲ့ link လေးကတစ်ဆင့်ဖြည့်ပေးလိုက်လို့ရပါတယ်ဗျာတိတ်မကြဘူးကျွန်တော်ထပ်ပြီးတော့ပို့လိုက်အောင်မယ် survey form ဖြည့်ဖို့အတွက်လေကျွန်တော်ဒီ session ကိုမသိမ်းမဲနဲ့ဒီလိုလေးထားပါမယ်နော်ဟိုဆရာပြင်ပန်းသွားပြီပေါ့အများကြီးပြောရတယ်ဆရာအနားယူခြင်းအနားယူလို့ရပါတယ်ခင်ဗျာဆရာ
Okay. Thank you.